Hello everyone, and welcome to another audio podcast around this series, the Busta Cap series. This is the Shientist. It's another Storm Robotics production. This is part one of an important topic relating to the need to consider renal health in transfusion care and research to inform best practice. And this is part one of a review that was done a little while ago now, and in collaboration with the Renal Patient Support Group, or the RPSG. Generally, I'm going to provide a bit of background, and part two around this work highlights a literature review in keeping with the remit of this work. So a bit of introduction. Patients with long-term conditions, or LTCs, as is abbreviated in this work, and chronic illnesses, or CIs, account for around 50% of primary care health appointments, 64% of outpatient appointments, and around 70% of hospital, what's been known as hospital bed days. And around 70% of total health and care expenditure in the UK is attributed, or has been attributed, to patients with long-term conditions and chronic illnesses, unfortunately. So patients diagnosed with a number of long-term conditions are or have been referred to as the most intensive users or service users of healthcare services, because the needs of those with long-term conditions in literature has highlighted that the needs are complex, or can be complex, more so than those who are sort of referred to as sort of one-off users in relating to aspects of healthcare. So most patients, however, aged 65 years old, 65 years of age, and also have more than one comorbidity, or referred to as multi-morbidity, although a recent Scottish publication found the absolute number of patients with multi-morbidities was actually higher in those under the age of 65, indicating its implications for the population as a whole. So between 2010 and 2030, it had been estimated that the number of younger adults with longer term conditions or chronic illnesses aged between 18 to 64 was set to rise just over 32%, and from around 220,000 to about 290,000, and the number of younger adults with physical or sensory impairment was set to increase or rise from around 7.5% to almost 2.9 million, to around from 2.9 million, around 2.9 million to 3.1 million. And furthermore, rates of the long-term conditions or chronic illnesses are increasing, or have been increasing, due to population aging, among other causes. In relating to this as well, patients with long-term conditions or chronic illnesses may not be considered suitable or not able to receive red blood cell transfusions because of health complications and also renal insufficiency, which is important in which is important, and patients may thus be deemed untransfusable, and there is no universally accepted treatment guidelines or frameworks for managing transfusion care in patients with long-term conditions or chronic illnesses, and practice differs between hospitals, regions, and countries. Transfusion practices are developing, incorporating many novel pharmacological agents into care in view of the potential longer-term risks. Excuse me. In the potential longer-term risks and side effects of red blood cell transfusions, and so there is ever more need to consider renal health or kidney health of patients who require transfusion care, especially where renal function is important in the synthesis of the hormone erythropoietin or EPO, and where renal insufficiency is evident. This can be the difference between morbidity and mortality. So although these risks are well reported and have led to a re-evaluation of the criteria for the use of blood products, and there is a particular practice guidelines around that, a specific portion of transfusion practitioners across laboratory practices have not really modified their approach. That notwithstanding, that laboratory practitioners and scientists generally would follow what are known as standard operating procedures. However, that being said, the approach has not been altered or modified because of the fear of the fine line between mortality and morbidity relating to anemia, especially in untransfusable patients and or patients at risk of developing forthcoming potential complications as well. So a little bit about health and red cell blood transfusion or RBT care. So the ability of red blood cells to facilitate the transportation of oxygen from the environment to the mitochondria at cellular level has been repeatedly demonstrated in physiology research, specifically. The physical characteristics of red blood cells or red blood cell transfusions the physical characteristics of red blood cells allow them to increase the solubility of plasma from oxygen by an estimated 30-fold. In addition, the affinity of red blood cells for oxygen is modulated by regional acid-base conditions to favor oxygen loading and at the pulmonary alveolar capillary interfaces, as well as unloading at the tissue level. At present, however, there are no clinically available fluids that have the loading and unloading carrying properties of red cells or blood. Biomedical and clinical intervention and the decision when to prescribe or administer red blood cell transfusions is not always routine. Having an appreciation and a knowledge of chronic kidney disease and renal insufficiency from an interventional perspective is also important, because in the management of patients who may have kidney disease, the kidneys will have to be monitored, and also because the kidneys generally have a critical role again in the synthesis of red cells through the hormone erythropoietin or EPO. So whilst synthesis of EPO may not be compromised in patients with renal insufficiency, there is a fine line around this, and there are publications around that as well. If there is evidence of reduced estimated glomerular filtration rate, or eGFR, leading to chronic kidney disease, this can potentially affect patients' overall hemoglobin. With chronic kidney disease prevalence steadily increasing, scientists, whether biomedical and clinical, generally find that that there can be a tough there can be a tough situation. Can be a tough situation because scientists, whether clinical scientists or biomedical scientists, in hematology and transfusion and across biochemistry laboratories as well, generally need to consider further renal health of all patients with long-term conditions and chronic illnesses, where red blood cell transfusion may be warranted or required to achieve best practice according to patient care. In relating to that, however, the question still is, apart from those who are suspect or high risk for renal insufficiency, why consider renal health in all patients? So part of this research was to investigate that very question. So this is actually a very important question that scientists in transfusion historically haven't been keeping up with, but generally speaking, it's a question that that scientists should be prompting or asking routinely, and considering the renal health and blood physiology of patients who require red blood cell transfusions in future is key to achieving best practice, more so now than ever, not least because chronic kidney disease prevalence is increasing, but also because transfusing patients with reduced estimated glomerular filtration rate or renal function in patients with a chronic illness or long-term condition can further compromise renal function over time. So with renal function decline, this has an impact on overall treatment and care plans. Patients then potentially become untransfusable completely. And so I'm now going to give an example of some context that came out of the literature. A practice, a GP practice of around 10,000 patients will have at least 500 patients with stage 3 to 5 chronic kidney disease, with approximately around 15 to 20 of these in chronic kidney disease stage 4, and then around 5 to 10 patients in chronic kidney disease stage 5. A more elderly and more deprived practice population are likely to have a higher prevalence. Of the 500 in CKD stage 3, around 84%, so 422, will have stage 3A, and 16%, around will have of the 500 with stage 3, 84%, around 422 patients will have stage 3A, and 16% 68 patients will have. Sorry, I'm going to repeat this again. Of the 500 with stage 3, 84%, 422 patients will have stage 3A, and 16% will have 68 and 16% will have stage 3A, so specifically 3A, and 55 patients will have 16%, which is 3B. So this then means that about 90% of patients with stage 3 to 5 will have hypertension, will have high blood pressure, or can have high blood pressure. 40% will have vascular type diseases, and 30% will have diseases, for example, like diabetes. Full details of sort of the statistics around this can be identified through the Health and Social Care Information Center HSCIC website, but also the Renal Registry, and also through the Renal Association. And generally speaking, patients with chronic kidney disease are roughly 20 times more likely to die from cardiovascular disease than to progress with chronic kidney disease. The all-cause mortality rate in chronic kidney disease is 30 to 60 times higher than in the general population, and scientists, clinical teams now need to question generally what are the clinical implications for transfusing patients, and the decision need to transfuse safely if at all. Hence, generally why it's important to consider renal health in all patients. I'm now going to talk a little bit about the clinical factors and the decision to transfuse. So clinical decisions are still challenged or questioned, relating patients' understanding and professionals having the knowledge about management guidelines, personal experiences with transfusion, and attitudes and beliefs about how best to manage anemia in patients with long-term conditions or chronic illnesses. Biomedical or laboratory techniques and research have developed over time, especially with regard to blood grouping, serology, and cross-matching. That being said, the clinical importance around red cell storage, and red cell storage lesions, for example, i.e. the time-dependent metabolic, biochemical, and molecular changes that stored cells undergo, is generally across the literature is still lacking, and so red cells can be filtered, washed, frozen, leukodepleted, irradiated for specific conditions, and donor screening and testing have dramatically reduced infectious rates and risks in the developed world, making transfusion more widely accessible. But at the same time, infection remains a major hazard in developing countries. So, for example, where 13 million units of blood retrospectively had not been tested or screened for human immunodeficiency virus, or HIV, or hepatitis virus. Despite serious immunological and non-immunological complications, red blood cell transfusions still actually hold the therapeutic index that exceed that of pharmacological interventions, where red blood cells or red blood cell transfusion replacement is where red blood cells replace red blood cell and red blood cell transfusion is concerned. A little bit about some guidelines and frameworks, and some guidelines, an overview on guidelines and frameworks here. Whilst there is now also more awareness of chronic kidney disease and early referral strategies for the management of patients with markers of chronic kidney disease or renal disease, patients who are due to be referred or symptomatic and have a form of chronic kidney disease generally have their hemoglobin assessed. Scientists and transfusion practitioners who are sort of enhancing skills should look to review guidelines and frameworks, updating the understanding relating to strategies for transfusion therapy. Actually should look to become more familiar with those sort of clinical guidelines, including the National Institute for Clinical Excellence, or NICE, the definitions around renal anemia, and using a particular threshold levels as a basis for aspects of transfusion practices. Retrospectively, using a threshold of 11 grams per deciliter to define anemia and the need to, and the need for treatment thereof, used in chronic kidney disease, and cross-reference with guidelines used by European best practice guidelines and kidney disease outcomes quality initiative, or KDOQI, are and have been sort of the foundation in relating to aspects of practice, at least where a clinical or medical practice is concerned. Reviewing guidelines, however, is a good start and recommended to ensure that practices are sort of robust, and patients with chronic kidney disease stage 3B and have, for example, hemoglobin of less than 11 grams per deciliter should be screened for anemia. The mean hemoglobin declines as renal function reduces in subsequent stages of chronic kidney disease, and this is when anemia then catches up with additional clinical symptoms. It is noted that the guide can be used for all patients with long-term conditions and chronic illnesses. Transfusion practitioners in laboratory medicine now use a threshold of around 8 grams per deciliter, or less than 7 grams per deciliter. However, that being said, the grams per deciliter in related to hemoglobin there's no sort of universal or overall consensus in relating to long-term conditions, health conditions around in and around across healthcare generally. 11 grams per deciliter when this work was developed. 11 grams per deciliter was specific to the renal population, or those being diagnosed with a form of chronic kidney disease. So the hemoglobin generally varies according to practices of those who request red cells for transfusion, for example. Although red blood cell transfusion in the UK is generally safe, indeed, most serious adverse events originate actually in the hospital rather than at any particular sort of blood transfusion center or donation site, blood donation center. However, ensuring a safe and effective blood supply remains essential. This requires a combination of high-quality donor recruitment and selection, increasing screening, serological testing, and blood component production, followed by rational clinical use. And so, generally speaking, There are 4 UK blood services, and there's the National Health Service, or NHS Blood and Transplant, or NHS Blood T, NHS Blood and Transplant, and NHS BT. There's in England, there's or in the UK, as part of the UK. Then there's the Northern Ireland Blood Transfusion Service. In Ireland, there's a Scottish National Blood Transfusion Service in Scotland, and then there's the Welsh Blood Service, which all maintain common standards for blood donation, screening, and screening of blood components and products. And in line with this also is the joint UK Blood Transfusion Services, or UK BTS, and the Joint Professional Advisory Committee, or JPAC, and they're responsible really for producing the guidelines and practices for blood transfusion services in the United Kingdom, and in line with this, the guidelines around blood transfusion services in the UK are referred to as what is known as the Red Book, and although not in this particular in this particular slide, the Red Book is in line with the MHRA, which is known as the Medicines Health Research. The Medicines and Health. Medicines Health and Research Authority, MHRA. And in 2011, actually, the UK Blood Services issued 2.1 million units of red cells, 300,000 platelet doses, 288,000 units of fresh frozen plasma, and 126,000 units of blood component known as cryoprecipitate. And I'm going to talk a little bit about transfusion alternatives. Different transfusion alternatives are known for intra, and post-operative periods, and autologous blood donation and erythropoietin or EPO-based pharmacological stimulating agents tend to be efficacious in the perioperative period. Intraoperatively, acute normovolemic and hemodilution cell salvage, antifibrinolytics, specific anesthetic and surgical techniques, coagulation monitoring, acceptance of minimal hemoglobin values, and artificial oxygen carriers can all reduce the use of allogenic red blood cell transfusion generally. And in the post-operative periods, cell salvage, antifibrinolytics, and accepting minimal hemoglobin values represent alternatives to red blood cell transfusion. Red blood cell transfusion and alternatives to red blood cell transfusions should be given sort of a strong consideration, and however more focused evaluations of specific long-term conditions and chronic illnesses, long-term conditions and chronic illness patient populations, and transfusion alternatives will help to clarify sort of the best use of treatment options, taking into account renal function. And I want to say that this audio podcast is now at an end. I want to say thank you for listening. The second part of this audio podcast is focuses on the literature review aspect that was in line with this work when it was initially conducted, and so that will be that audio podcast will be part of this. And so this has been a kind of for me, it's been a sort of a reminder, because it's been a while since the research had been conducted. But I hope it's been useful. Feel free to use the timestamps in the YouTube video to in the YouTube video to make your own notes. But generally speaking, feel free to also contact the collaborators, the Renal Patient Support Group, or the RPSG. And this has been another audio podcast under the Storm Robotics. This is the Shientist. And again, thank you for listening, and hopefully we got there's another few more audios and podcasts under this this series known as the Busta Cap series. So thank you once again, and hopefully catch you on the next one. Thank you.